Very much indeed, and it's a real pleasure and honour to be invited to participate in this meeting. And as has been said many times this morning, the rest of the UK keeps looking at Wales as the leader in FLS, but also I'm going to talk about what happens beyond FLS. I've been asked to speak about what are the high-risk groups, and groups always cause me concern because as a clinician, you've got an individual sitting in front of you, and you want to do the best for that individual. But doing the best for the individual is not enough, because we've got a fracture burden in society. And if we do the best for one individual, it's great for that individual. But if we don't do the best for lots of individuals, we're going to have no impact on the burden of disease. So a lot of it is combining individual management with good public health approaches to identifying people. These are my disclosures. At the bottom you'll see there that I am a director of Osteoporosis Research Limited. It says pro bono. That doesn't mean that I'm a big U2 fan. It means I am a big U2 fan, but I also don't get paid as a director of Osteoporosis Research Limited. So really what I wanted to do was just to talk a little bit about setting the scene for high risk, and why we've heard throughout the morning about risk. High risk, very high risk, and what do we mean by that, and how have we got here, and how does that work for us going forward in the management of patients. And then approaches to identification, and there are targeted groups, but there's also the possibility for population-based assessments, and we've, in the previous session, had talk about screening, and I don't think we need to essentially get to screening to have a full structured screening program where people get invited for DEXA scans or risk assessments and things, but there's a real opportunity within the electronic and digital systems that we work in now to actually make this part of routine practice, make risk assessment part of routine practice if we can implement it appropriately. So osteoporosis, we've heard this morning, it's a chronic disease. It's very similar to other non-communicable chronic diseases. And I've divided them in here into two parts. There are those which are the events. So fractures are events. We've heard that expression this morning, that occur in the life of usually elderly, sometimes frail individuals. But we know that there are risk factors for those events. And those risk factors often get characterized as being diseases. So high blood pressure for stroke, set the threshold, you define hypertension. You've either got hypertension or you don't. Whereas the relationship between blood pressure and stroke is not, if you've got a blood pressure of 139/89, you're at no risk of stroke, and if you're 141/91, you're at increased risk of stroke. It's not a dichotomous schedule, it's a continuous relationship between that measurement and the outcome. So that's really why in many of these diseases we now have risk assessment tools, and these are just examples from the European Heart Score for cardiovascular disease, the US model. In the UK we've got Q-risk 3, and in osteoporosis we've got Q fracture, we've got the FRAX model that I'm involved with. And like many of these diseases, you'll see that the risk factors are shared. Older age is a significant risk factor for all of these things. There are differences between men and women in the likelihood of disease. Smoking, lifestyle factors are in there. Family history is important, certainly in both cardiovascular disease and in osteoporosis. But you can put all of this information together to work out the future risk of the individual that's sitting in front of you, as well as using the population levels to identify groups that are at high risk of fracture. And fracture, the whole first session this morning was about FLS and fracture. And fracture, the end event, as we heard this morning very honestly and openly, that if someone presents with a heart attack, they go home with 3 or 4 drugs and lots of advice how to manage them. And in osteoporosis, that still doesn't happen in the majority of patients with fractures. But it's also important not to forget that fracture itself is a significant risk factor. And we saw many discussions about the impact of recent fracture, increasing the risk within the first 2 to 3 years, and that enhances therapeutic approaches, but whether we should be using anti-resorptives or anabolic treatments in the first line. This is just data from a study that we did many years ago in and around Sheffield. We recruited just over 5,500 women aged 75 and older living in and around Sheffield. We randomised them to a double-blind placebo-controlled trial of an old bisphosphonate called clopidogrel. But on the left, I've just divided them into quartiles for their baseline fracture probability. And you can see that in the open circles, patients without fractures have a spectrum of risk. But even the patients with fractures have a spectrum of risk. And there are some patients with fracture, given their other features, that will be at relatively low risk of future fracture. And there are some patients with fractures who will be at much higher risk of fracture. And that just allows us to stratify the risk and not just help us to make a decision about should I treat or not, but what should I treat with to reduce that individual's fracture. And on the bottom right, in part of the FRAX platform, now we've got this FRAX Plus add-on that allows you to adjust for recency of fracture within the last 2 years for recent vertebral fractures, hip fractures, wrist fractures, and so on. So there's a continuous relationship between the measurement of blood pressure, the measurement of bone mineral density, and fracture risk. And actually, this was outlined back in 1994 when the T-score was invented. Does anybody know why it's called the T-score? Okay, it's for Tom. So it's Tom Kelly worked for Hologic, and Tom Kelly came up with the T-score. So it's T for Tom. So I'm actually speaking to him on a phone call tomorrow evening, but the T-score was set up as a threshold for the diagnosis of osteoporosis. And that was almost an epidemiological tool to allow us to define osteoporosis, that we could compare it across the world, across societies and so on. But it was recognised in the document that there was a continuous relationship between bone mineral density and fracture risk. And the potential as a prognostic tool could be treated differently from the diagnostic tool, and we shouldn't forget that it's still a prognostic tool. And the interesting thing is that we have similar arguments going on in the cardiovascular world as we've had in the bone world about should we treat if you've got a T-score of minus 2.51, yes. If you've got a T-score of minus 2.49, no. And those risks are virtually identical. And we set this threshold. And the same was true in the cardiovascular world, where the diagnosis of hypertension was 140/90. And this is a lovely study published in the Lancet back 5 years ago, now 6 years ago. They looked at 48 studies with lots of individuals. You can see the numbers there. And some individuals went into that study with blood pressures below the 140/90 because they'd got other risk factors. And what they found was that the lowering of blood pressure still reduced their risk of heart disease, even though they didn't have hypertension. And so in red letters there, you can see this is the suggestions that blood pressure lowering treatment is only effective in the presence of blood pressure above a certain threshold. We now have good evidence that that is true for bone mineral density, that the drugs work above the magic T-score. And that this study calls for a revision of the cardiovascular guidelines that calls for consideration of blood pressure lowering treatment in any individual who has a sufficiently high absolute risk of cardiovascular disease. And they recommend using risk tools rather than a single measurement of blood pressure as the determinant of whether intervention should be required or not. So what about the groups? Well, I'm not going to spend too much time on this because I've got 5 minutes and 40 seconds left. But the groups, the big group is prior fracture. So we've talked this morning about FLS. The FLS are picking up recent fractures, and going forward, if we can implement that, that's going to pick up gradually over time, essentially almost everybody who has a fracture. But there are other groups out there, and the other common group that you will know is the group of corticals. But if you look at prior fracture, this is a cohort that a synthetic cohort of the UK female population at the age of 50, and you can see that 30% have a prior fracture. That drives most of the risk. But secondary osteoporosis is about 18% in that age group. And again, that falls down to different specialties. So we've worked together with rheumatology over the years, looking at the risk of fracture in inflammatory joint diseases, in corticosteroid users, and so on. So this is something that often falls to the specialty doctors that are looking after that particular secondary osteoporosis. But again, a lot of it falls between the stools and ends up back in primary care and is not always detected. But rather than focusing in just on these groups, I'm more interested in population approaches to answering this question. And one of the problems is, well, one of the benefits is that we've got electronic patient records. So everything is digital these days. There's a lot of information in those databases, but they are not perfect. So there's a recent study from the CPRD looking at risk factors for fracture, and about 1/3 of individuals did not have their BMI available. About 1/4 didn't have any information on their alcohol intake or their smoking exposure, and so on. So we're just doing a study at the moment where we're actually allowing patients to potentially fill their own GP record. So we live in a time when we can text our patients, we can provide links for them to answer questions, and that information could be captured within the electronic patient record. And this is just under 6,000 patients that we contacted through GP surgeries across England and asked them about their history of prior fracture and their height and weight to calculate their BMI and so on. So there's a possibility there of interacting not just with the patients and doctors, but the patients and public health to try and improve the identification of such patients. What do NICE say? I don't always agree with what NICE has to say. I used to call them the National Institute of Conservative Economists, but the guidance around who to undertake a fracture risk assessment in, I think, is a very reasonable one. And they're considering assessments in all women aged 65 years and older. So we're talking about screening. That's essentially saying you should be screening all 65-year-old women and older, or old men aged 75 and over. But they don't use the word screening, and we know that screening is a different ball game. It has lots of cost and lots of structure that needs to be in place. But enhanced case finding is something that we could be doing within electronic patient records. So the other recommendation was that with those risk factors and those age groups, that you should be undertaking a risk assessment with FRAX or Q fracture, send them for a bone mineral density if that's required, and then feed that information back into the risk assessment. Not to look for the magic T-score of T minus 2.5, but to take the bone density and put it back in as a risk factor into the risk assessment. And of course, as you know, that there's an update of the NICE guideline being considered at the moment, and that will potentially be out in the public domain at the end of July. It'll be interesting to see what that concludes. How do we intervene? Again, whenever we launched FRAX in 2009, we realised that we needed some guidance, and the National Osteoporosis Guideline Group was devised. This is the latest graph from the National Osteoporosis Guideline Group, where you can press, when you do the calculation of the UK FRAX tool, there's a button that appears that you can see NOG Guide, which you click on the NOG Guidance button and it takes the results through to the NOG page and puts them on this traffic light coloured graph to tell you what you can do in primary care or elsewhere. And again, you can see that we've now got two different shades of red. One is high risk, predominantly considering anti-resorptive therapy. One is very high risk, considering referral to a local specialist for consideration of bone-forming treatments. We did an audit of the whole year of 2024 on the NOG website, and you can see this just looking at the number of views over the year. Just under 1 million, over 900,000 views over the year. That's 3,500 views a day. 2/3 of those arose from people pushing the button on the FRAX website through to the NOG website. and 2/3 of those were calculated without femoral neck BMP, so it has been used appropriately as NICE suggested that it should be done to assess whether this patient requires a bone mineral density assessment or not. And we can make much better use of bone mineral density assessments if we target these measurements to people who sit at or near the intervention threshold, because that's the people in whom that extra bit of information is going to change. So finally, I'm running out of time, so the SCOOP study. The SCOOP study is the only study to date that has targeted treatment on the basis of fracture risk, and in particular hip fracture risk. The study at the right, people in the treatment subgroup within the screening arm had a hip fracture risk of 18% in 10 years. Hip fracture risk of 18% in 10 years. And treating with good old oral bisphosphonates and oral alendronate in general, which I agree is not perhaps the most useful drug in the setting of post-hip fracture patients or elderly infirm individuals, but they reduced the incidence of hip fracture by 28%. Just treating 14% of the screening arm reduced the hip fracture risk by 28%, and that was targeted to the group that were recommended for treatment at high risk. So in conclusion, I think that we're at the FLS meeting, and FLS are an essential and increasingly, hopefully, efficient mechanism for identifying patients at high risk. Outside the FLS, then primary and secondary prevention still exists, because secondary prevention, not everybody with a fracture out there has gone through an FLS, and they're still out in primary care, and they're still at twofold higher risk of fracture in the future, just having had a prior fracture. So primary and secondary fracture prevention remains the responsibility of various specialties, particularly primary care with a big role to play. The NICE guidance, I think, on risk assessment identifies a reasonable approach. The question remains as to how best to implement that. And the absolute risk of outcome is becoming established in intervention thresholds, not in the definition of the disease or the diagnosis of the disease, but in the decision about who to intervene in non-communicable diseases, including osteoporosis. And I'll stop there. Thank you very much.